Hello and welcome again. We're going to cover Chapter 10, which covers respiration and artificial ventilation, where we're going to learn the processes of manually ventilating and controlling the airways of our patients. First, we're going to cover the physiology and pathophysiology of the airway. Mechanics of breathing, as we've discussed many times, ventilation, that's the actual process of moving the air in and out. So we've talked about different things of ventilation, respirations. Just remember that ventilating is what we're going to be doing to put the air in and out of the patients. We'll be doing that with some different devices and everything. I gave these analogies a couple other times, but the mechanics of breathing is similar to that of a medical syringe. If you see here of the plungers of these syringes in different shapes and sizes, that plunger is just like your diaphragm. So as your diaphragm goes down, it pulls air into the body. With all that happening and your muscles contracting, that makes it an active process. So those muscles expand, diaphragm comes down, the muscles in between your ribs tighten, opens up your chest cavity, gives more room for air to come in, making that active process. So it's a negative pressure that's pulling air in. So when we're talking about controlling a patient's airway and manually ventilating them, we do a positive pressure. But the active process of the body's a negative pressure pulling it in. Just like I said at the higher elevations, like in the nice picture over here. Over here, it's a little bit easier to breathe than it is way up here. Because when you get it way up here, you've got just this little syringe and a little plunger trying to pull just lower amounts of air in. Now, exhalation is a passive process where the active process of bringing the air in was the muscles contracting. The exhalation process being passive was muscles relax. The diaphragm goes straight back up into its naturally curved position. The thoracic cavity gets smaller and that air releases, equalizing out the pressures. So just that air movement is equalizing of the pressure inside your chest cavity and the outside atmospheric air. Terms, again, as review of tidal volume. That is the amount of air moved in the body in one single breath. And that's at rest, is what the average of 500 milliliters is the average person at rest takes one breath in that equals on average about 500 milliliters. Now there's some math that goes into that of how it's calculated, because generally bigger people can take in a deeper breath. So about 5 to 7 milliliters per kilogram of ideal body weight. That doesn't mean how much they currently weigh. It means how much they probably should weigh. Now, minute volume is how much air is moved in during 1 minute's time. So you take that tidal volume and how many times they do that breath in a single minute. So you take a tidal volume times the respiratory rate equals that minute volume. Now, that's important to remember. We talk about that's will determine how well their airway is being managed and how they may try to compensate. So if they're getting less of a tidal volume, they're going to increase that respiratory rate, trying to get in that same amount of volume per minute. Dead air space is basically the air that's going in that's not having any kind of gas exchange, not getting all the way into the lungs, just dead stuff. So basically that's the non-respiratory parts from your nose and your mouth on down in the part that doesn't have any kind of process with gas exchange. And that averages out to about 150 milliliters of air that's not really having any process dealing with gas exchanges, just air movement going in and out. Now, all that ties into the alveolar ventilation. That's the volume of air that actually gets all the way to the alveoli. So more math equations with this. All that is you're not going to be figuring out this math in the back of the ambulance. It's just a relative explanation of what goes on. So with the Bohr equation, it's your tidal volume minus the dead space volume equals that alveoli volume. So all the air that you're taking in that one breath, about 500 milliliters minus that 150 milliliters equals how much air is going to get into the alveoli. So you can think about that in compensatory ways, that if that tidal volume gets less, and that dead space is always going to stay the same, because the person's not growing and stretching or shrinking when they're having problems breathing. So that dead space stays the same size. So if that tidal volume goes down, that's less volume of air that's actually going to get to that alveoli. In the last class, I talked about different pressures and concentrations of everything. So at an in-depth level, that's what makes the oxygen get onto the blood cells and the CO2 come off. It's just a movement of gases from a higher concentration to a lower concentration. So those O2 molecules and the CO2 molecules have different gas concentrations, so they're going to go in opposite directions. With external respiration, that means that's the diffusion of the oxygen and that CO2 at between the alveoli and the blood. But at the internal respiration, that's the exchange of gases between the blood and the cells. So it's external respiration that gets everything down to the alveoli level into the blood. But then the internal respiration is once it's in that bloodstream, what happens at the cellular level. So internal respiration is cellular, external is more volume and into just the bloodstream. So at that cellular respiration, oxygen from the blood is diffused into the cell, and CO2 is diffused from the cell into the blood. There again, that's just the diffusion process going from a high concentration area to a lower concentration area. There are some instances that can disrupt those respiration and diffusion processes, such things as a altered mental status, whether it's caused from trauma, narcotics, whatever it may be, some kind of depressant, alcohol overdose, anything that's going to change that mental status and potentially affect the respiratory drive. So that's going to affect the gas exchange. Also with that, if you have somebody who has carbon monoxide poisoning, as we talked, that's found in the house from incomplete combustion. Say somebody has a faulty furnace, they're using a heat source that's not appropriate for indoors, it should be outside where it's well ventilated, because carbon monoxide has about a 300 to 400 greater affinity to bind to that red blood cell than the oxygen can. So CO is super sticky, loves red blood cells. Red blood cells love CO, so they'll adhere to it at a much greater rate than oxygen can. So the red blood cells will hold on to that carbon monoxide and not let go. So that oxygen comes in, there's no seats for it left on the boat, so it just sits there. It doesn't get onto the bloodstream. That's important to know whenever you put the patient on pulse oximetry, because a pulse oximetry, which shows their oxygen saturations, will only detect that there is something adhered to the red blood cell. It's just it's an infrared light that shines through into your capillary vessels, sees that there's a red blood cell there, there's something adhered to it. It doesn't know if it's oxygen or CO, it just knows something's there. So your pulse ox may say 97%. So you think, oh, okay, well they've got good saturations, but that could mean that that's just carbon monoxide there, not oxygen. But there are carbon oximetry readers that can tell the difference between the oxygen molecules and the CO. Other things that could interfere with that gas exchange are chronic lung issues such as COPD and cancers, things like that. Anything that's got that lung tissue damaged at the alveolar level can affect that gas exchange from going. Also, if you just have circulation issues, say blood loss, the hemoglobin's gone, there's no red blood cells there for the oxygen to adhere to, they're going to be hypoxic. There's not going to be a gas exchange because there's not much at the cellular level happening. Also, with low blood pressure, as we talked about with the anatomy, if there's not enough force to be shoving that blood through, it's just not going to be enough cells coming through that barge, at the dock, enough time to be getting all the oxygen molecules. Now we'll talk about the respiration process. Just remember we talked about Krebs' cycle, how the body needs oxygen and good amounts of glucose. And oxygen is very, very important for everything to happen in that energy production. The body needs the energy production for ATP to occur, because without ATP, the body's not going to have any energy and nothing to be able to run on. So if you have a hypoxic patient, meaning the low oxygen levels, which is generally anything below 94%, is considered hypoxic. Also that CO2, remember the chemoreceptors will be in the bronchioles and other airway passages, measuring out those levels of CO2, and that's going to be a big force determining the respiration rate and everything. Trying to exhale, get all that CO2, all that off-gas stuff out of the body. So terms to remember for CO is capnia. We'll talk about capnography, means the measurement of CO2 levels in the body. So hypercapnia means that there are high levels of CO2. So for high levels of CO2, that body's going to be trying to breathe faster to get that CO2 out of the body, because yes, there is certain levels of CO2 that stay in the body that are at an acceptable range that keeps the respirations going as it should, but too much is not always a good thing, especially when it comes to CO2 in the airway. When we're assessing the patient's airway, we're essentially assessing how well the whole cardiopulmonary system's working, if they're able to be getting oxygen in, and if they're getting the CO2 removed out. That whole complete process of respiration is what we're looking at and trying to determine, not just is their mouth open or is it closed. So we're trying to analyze more in depth of that whole process. Respiratory distress is the compensatory mechanism of the respiratory cycle. So there's major metabolic issues going on, whether it's O2 levels, CO2 levels, something is causing that respiratory distress. So this is a major distress factor when they can normally maybe increase their respiratory rate a little bit and they maintain and they compensate, but when they get considered to be in respiratory distress, that means that they're starting to decompensate in their respiratory patterns, that the just normal increase of respiratory rate wasn't enough to balance it out, and now they're starting to really go downhill. This is also considered to be respiratory failure. So just because you see somebody who's breathing heavily, you need to analyze whether they should be breathing heavily or not. Say the patient who called you for something who was in the middle of running a marathon and is breathing really fast. That may not be an indicator that they're in respiratory distress. But if the person's having major airway issues and they're at rest, that's the big indicator and the difference of someone being in respiratory distress. That's, like I said, gonna end up being respiratory failure. So if they're starting to decompensate or going downhill, the respiratory cycle has failed. And if it's not corrected quickly or managed, or if the underlying cause is not reversed, they will go into respiratory arrest, meaning that they just quit breathing. Some indicators for somebody having major respiratory distress, as you see in the picture here. You got a person in that tripoding position. They're setting up, they got their hands on their knees, they're slumped forward, they've got that arch back, and probably if you would see under the shirt, those muscles in between the ribs are going to be retracting in. The body's working hard as it can trying to get that air movement in. Whatever it can do, it's trying. So the more effort is put in to try to get that breath in, whether it's the breathing pattern changes, the body positioning changes, there's more muscle work going into it, all a cascading effect of respiratory distress, which will end up leading to respiratory arrest, meaning they're just going to stop breathing. Let's talk about the patient assessment and assessing that airway. So obviously, signs of adequate breathing is they've got a normal mental status. They've got enough oxygen in there to be producing ATP, to be making their eyes open, making them alert, making them normal. So with that, they're going to generally have a normal pulse oximetry reading, 94 to 99%. And that normal skin color, a good pink, warm, and dry. With signs of inadequate breathing, you're going to have absent or minimal chest movement. So if you take a deep breath in and your chest comes up equally, you may not see that in these patients. They may not see any or much chest movement at all. So right now, I just want you to put your hand on your chest, take a deep breath, and see how much your chest actually moves. So that's what you should be looking for. It really is not a whole lot of movement in it, but you will see that there is some equal movement in it, as well as the left and right side come up equally. So if there's issues with maybe only one side coming up, you've got a major issue there. That if only one, that would mean that only one lung's inflating, or the other one's maybe not inflating at all or very little. If they've got abdominal breathing, even at the adults, not just babies we talk about as their belly breathers, but if the adults start trying to use their abdominal muscles to try to pull in more air, or they're using muscles around their neck, the muscles contracting in between their ribs, or they're just throwing their whole head into it, any kind of different muscle use or body positioning is going to indicate inadequate breathing. Also, if you hear any kind of those crazy breath sounds across the room, you hear them from afar, of that high-pitched sounds, or you hear a gurgling, it sounds like they're choking on creamy mushroom soup, those are bad indicators. You will hear the sound of death gurgles in your career, I can assure you, where that patient's got fluid and edema build up in their lungs, and it's basically starting to seep out all the way up to their mouth. So if you can hear airway sounds without a stethoscope, that's a very bad indicator of an airway issue. Also, if their breathing rate's too rapid, too slow, too deep, too shallow, anything out of the norm, then if they start to develop other skin tones other than pink, warm, and dry, such as cyanosis. Now, cyanosis is the bluing of the skin, and you'll generally see that first around the lips, around the nose, the fingernail beds, around the eyes. You'll see that stuff start to become kind of bluish, pale. Mostly the bluish is going to happen around the lips first. Those really small, fine capillary areas will become blue. Now, and also, when you're assessing these patients, we think about different races and stuff, talking about pink, warm, and dry skin. Not every patient has pink-looking skin everywhere. You think about persons from Asia, Africa, different places. They've got different skin tones, but cyanosis will still be the same around the lips, in the gum area, at the nail beds. So that's where you want to be looking for this cyanosis, because all races and genders will show cyanosis equally in those areas. So then also the retractions and nasal flaring in the kids. Once the kids start putting muscle work or movement into breathing, their respiratory drive is going to fail very fast, because kids will crash really, really fast. And then also low oxygen saturating readings on your pulse oximetry. You can't rely solely on that pulse oximetry, those oxygen saturation readings, so you got to look globally at the patient. Say some things that can skew a pulse oximetry reading is, since it's a light that shines through a nail bed, if the patient has, say, fingernail polish, just poor nail beds from smoking, or they've got busted fingernails or something, or if they are hypoperfusing, if they are in shock and there's not much blood circulation getting to that fingertip where you got that pulse ox at, it's not going to be a good indicator because there's not any blood there. So you can't solely rely on that. Also, it's just some really common things that can happen if you pick up a patient, say, in the middle of the winter, and that patient has really cold fingertips, that pulse oximetry reading is going to be low as well. So if your patient's sitting there not having any respiratory issues, called you because their stomach hurt, and that pulse oximetry is saying 80%, you may just need to reassess and think a little bit outside of the box on that. Major reasons for hypoxia is, biggest one you're going to see is lung diseases, COPD, asthma, cancers, things like that. People who just have normal episodes of becoming hypoxic from lung diseases. Also, other things like being in a hazardous atmosphere, whether they've been in a area of high concentrations of carbon monoxide and they've got CO poisoning now, whether it was a victim pulled out of a fire who has been exposed to a whole bunch of other kind of toxic gases and may have been completely apneic for a while. The patient who's overdosed, say your heroin overdose patient, who basically hasn't been breathing for quite a while, or if they were, it was only a couple times a minute, they're going to be hypoxic. Also, a person having a heart attack, if they've got damage to their heart tissue, the whole cardiopulmonary issues are going to be messed up. So you can think about if that heart had a big a big area of damage to its muscle, since the heart's just a big muscle, it's going to interfere with circulating that blood to be going and picking up all the oxygen. And in the cases of the trauma patient, where the hemoglobin, the red blood cells that the oxygen should adhere to, are on the interstate. Not much you can do for that, except get them to a hospital and get them blood. Now we'll talk about patient care of the person who has inadequate breathing. So we're going to provide artificial ventilation. We're mainly going to breathe for them, and we're going to give them our medical supply of oxygen. When you've assessed that they have an inadequate airway, you're going to be thinking, well, when do I need to intervene? Or is just giving them some oxygen going to fix the situation? But the airways are something that need to be dealt with very aggressively. You'll hear me say aggressive a whole lot with this, but I want everybody to be trained to be very aggressive with those airways, manage them, because if that airway starts to go, the rest of it's just a death cascade. The airway goes away, and everything else is just going to follow suit. So the patient who goes into respiratory arrest could end up shortly thereafter going into cardiac arrest. Then you're doing CPR and a whole bunch of other stuff. So we're going to provide the patient with positive pressure ventilation. So we'll be using some devices to manually breathe for that patient. If they've lost their respiratory drive, whatever the mechanism was, we're going to take over and breathe for them. The process of the positive pressure ventilation is just as it sounds. We're going to be forcing air into the lungs with positive pressure, where the normal respiratory cycle is a negative pressure, just pulling air in, we're going to push it in. So with that, the devices we use will have oxygen connected to it, so we're shoving a volume of high concentrations of oxygen into the lungs to aid them in their respiratory cycles. So, but there can be some side effects to that. So there's techniques to doing all this, and there's side things you need to be looking for to make sure you're doing it properly. So you can actually overinflate these people. So a bag valve mask, what we'll talk about later, is one way to provide positive pressure ventilation. Has a whole lot of volume to it. So you can put too much in there. So if you put too much air into the lungs and you've got that mouth sealed, the next place for the air to go to is into the belly. So you blow a bunch of air in, the lungs are filled up, it's going to backtrack and go down into the belly, causing gastric distension. And you can just imagine what kind of a mess it would be if you inflate that belly. So we talked about with lung stuff, it's just like a balloon. Well, the belly can be the same way. So you imagine blowing the belly up like a balloon, it can pop, or everything that's in there can be flushed back out and come up out of their mouth, and you don't want to get into that. Then you've got major airway issues when all the gastric and stomach contents come out. Also with that is if you over ventilate them, you get those lungs too big, that's going to decrease that cardiac output, because the lungs and the heart are in there kind of snug together. So if you overinflate those lungs and they're really big and you're pushing air resistance back against it, or just a whole lot of different kinds of resistance, it's going to reduce that cardiac output, the blood pressure is going to drop, and you can also hurt other things. Also with CO2 levels, if you ventilate them too much, those CO2 levels are going to drop. Just like if I said we're talking about patients managing that CO2 level in their body, if there's too much CO2, they'll breathe faster. But if you breathe too fast, the CO2 level is going to go too low. Some other things you need to be cautious of is if there's something in that patient's airways, such as vomit, the blood, the teeth, you got to get that stuff out, because if you force air in, you're going to shove all that stuff right down to and make your patient completely choke. So granted that the airway's clear and you're going to be doing it properly, whenever you breathe for them, you want to make sure you watch that chest rise and fall. Just like I told you, put your hand on your chest. When you take a deep breath, you're seeing how high that chest goes. That's what you should be looking for in that patient too when you breathe for them, is just for that chest to come up. Once you see the chest come up, that means the lungs are full. You don't have to shove any more air in. The chest comes up, lungs are full, you've delivered that appropriate amount of a tidal volume. There are some other forms that are considered non-invasive positive pressure ventilation, and these are all devices that will continually manage the patient's airway for you, to where you're not having to squeeze a bag or manually put your breath into their mouth. This is just more of a somewhat electronic and airway control devices. Now these are for patients who are breathing, to where manually we'll breathe for someone who's not breathing at all. But the CPAP is something that's carried pretty much countrywide on an ambulance, and the BiPAP is more of a in-hospital setting. Some ambulance services do use a BiPAP, and we'll cover those more in the lab. But the CPAP is just an acronym: continuous positive airway pressure. Basically, if somebody's having problems getting a deep breath in, it's a higher pressure, to where it's a device hooked up to them. Kind of looks like a mask that a fighter pilot would wear. So when they go and open up their mouth, it'll shove the air down in for them instead of you manually doing it. And the BiPAP does the same thing, but bi meaning two. There's two different types of settings you can do on it, where the CPAP's a continuous. There's just one setting you have on it. When it comes to manually controlling somebody's airway, one of the most basic forms of ventilation is to use a mouth-to-mask ventilation. We don't really do mouth-to-mouth anymore. It's taught with pediatrics, but not with adults, because if it's a stranger, we don't know what kind of diseases and stuff that they have. So the most basic thing is this mouth-to-mask setup. So you'll see here, it's got a little one-way valve on it, and then a mouthpiece here. This is where you breathe in, and this seal goes around the patient's mouth with their nose up here and their mouth down here at the wider part, just anatomically as the face is shaped. So you put that on there. This elastic strap can go around their head, and then you seal it on there well while wearing your gloves, and you breathe into this part. Now, one-way valves there, so you can blow air in, but if anything would come out of the patient's mouth, it's not going to go back into your mouth. For the patient without any kind of suspected spine injury, the patient who doesn't have any traumatic issues, you're going to have the person at the top of the patient's head, and are going to apply that mask, make the seal to the face, put the thumbs over the top of the mask, and your fingers around the bottom of the jaw, kind of creating a clamp. And you're basically going to pull the jaw up to that mask and make a tight seal, so that when you blow through that mask, all the air goes into the patient's mouth, not out around the seal. So lifting that jaw up, making the seal squeeze tight, and you just breathe in through that one-way valve. And while you're doing so, you need to look down the patient's body and make sure that you see the chest rise and fall. Now, if you don't see the chest rise and fall, basically you've got two options. You need to reposition that head. If you're at the non-traumatic patient, redo the head tilt chin lift, or reposition your seal. And if that's not working, you just need to always consider that there's a major obstruction in there somewhere. So this picture shows a technique of making that seal. You see the patient's head is in that upward sniffing position to the head tilt chin lift. The EMT here has his fingers around the jaw part, around the bony part of the jaw, not into the tissues. If you squeeze in here, you're going to shove that tongue down in. So he's got the mask sealed around there. He's got oxygen hooked up to that mask, running over here to his oxygen cylinder, and he's breathing in. So as he takes that breath, he should be looking down the plane of that patient's chest as he delivers that breath to look for rise and fall of the chest. Now, a bag valve mask is a little bit more common. And honestly, I've never used a pocket mask. I don't know many people who ever have. But it's a good form as a secondary backup. Now, the bag valve mask, though, is kind of a standalone thing. You can use it as two-person setup or one-person setup. It's kind of assembled just similarly to like what a bagpipe would be. So here it is, bag valve mask. I said in the last presentation, EMS people, we're not rocket scientists, so we like to keep it simple when we name stuff. So you've got a bag, you've got a valve, and you have a mask, a BVM. It's that simple. So this bag is what you'll squeeze to deliver the breath through the valve, through the mask, into the patient. I see here you have your oxygen connection that would go to your tank, and this is a reservoir bag. So when it's hooked up to oxygen, this reservoir bag fills up with 100% oxygen, so that every breath you deliver and you squeeze, it pulls air out of this bag, not out of the atmospheric air. Because remember, atmospheric air is about 21% oxygen. This bag here is going to be 100%. So you squeeze it, high concentration of oxygen into the patient, and these are set up as infant, child, and adult sizes. Little kids, little lungs. Big people, big lungs. The design of a BVM, it's pretty basic. So as you squeeze in the bag, that material, it refills itself. So as you squeeze, it's going to fill back up with air, re-expand, and then you're going to squeeze it again the next time when it fills back up. The one-way valve it's in, it's a non-rebreathing valve, so that if something did come up through the patient's mouth, it's not going to go and interfere with the process. It's not going to jam up that valve. It's not going to clog it up or get into the bag to where you basically have something in the bag and can squeeze it out as a projectile. It's just that one-way valve. So as you connect it, you'll connect that BVM to 15 liters of oxygen, and as you squeeze, all that oxygen comes out of that reservoir bag into the patient. One of the most preferred things and what's recommended by the AHA is a 2-rescuer setup. It's the most difficult part of this is creating that seal around a patient's face. Some people who have smaller hands have a difficult time trying to make that seal with just one hand. So the preferred method, depending on if you have enough people, is you have one person make the seal and another person be squeezing the bag. Now, 2-rescuer setup. Open airway mainly, head tilt chin lift as long as there's no trauma suspected. Get the appropriate bag valve mask. If you're working on an adult, get the big one. If you're working on a kid, get the one out of the pediatric bag. So the person managing that airway, as always, is at the top of the head. Just like a baseball field, every player has their own position, and the person playing the airway controller is at the top of the head. You make a triangular shape with your fingers, kind of making that diamond shape. So you'll put your hands over that mask, use your other remaining fingers to clamp around the jaw line, and you're going to squeeze tight. Pull the patient's face to the mask. Don't press the mask to the face. Even though it sounds like it's 6 as it is, half a dozen another, it's just a good theory to pull that patient's face up. If you try to press down, you're going completely against that head tilt chin lift maneuver that you've been doing. So pull up, don't press down. So here's a good picture of making that diamond shape around the mask and using those fingers around that on the jawbone, on the jawline, making the seal. And the other person's over here squeezing the bag. One of the biggest things I see in this picture is this guy doesn't have on any gloves. You need to have on your gloves. So making a seal, one other person does all the squeezing. Now if there's trauma suspected, it gets a little bit more complex. So now you've got to use that modified jaw thrust. So once again, you're going to be in the same position, up at the top, at the patient's head. You're going to be using the remaining fingers to, instead of kind of clamp the jaw, you're going to use that to where you use your palms on the side of the patient's head, maintaining that neutral position with the head, and be using those the fingers to lift the jaw up while still making the seal. It's a complex thing, a little bit difficult, but it's definitely doable. So here's a good picture. So you've got the thumbs up here, making that seal, down here on the bend of the jaw, lifting straight up. The other palms are securing the side of the head, and you lift that jaw straight up while the next person is squeezing the bag. You'll see here they got the oxygen tubing connected from here over here to their oxygen cylinder. So this is a bit of a complex situation, but it's definitely doable. Now the most common thing that you're definitely going to see in the field is the 1-rescuer, to where you're going to be managing the airway by yourself. So what we like to call it is making a CE method, to where you'll make a C, So if you take your thumb and your finger, you make a shape of a C. So everybody do that right now. Make a shape of a C. You know the three fingers, middle, ring, and pinky, are going to be sticking straight up in the air, and that's going to be your E method. So that C is what's going to be used to clamp around the top of the mask. Then the other three fingers are what you're going to use to hold on to the jaw. So you'll take those three fingers, squeeze up, pull the jaw towards the mask, and then you're going to squeeze that bag. And always when you're doing that, be looking for rise and fall of the chest. And then we get more in depth with it. We'll be listening to lung sounds, making sure everything's still going okay. But just use that CE method. And as redundancy, if you don't see that chest rise and fall, basic 3 steps. You either reposition the head, reevaluate your seal, or you see if there's some kind of major obstruction in there. Remember, if there is an obstruction, we don't want to go digging and sweeping for gold. Okay, only go in and dig out anything you can see so you don't make the obstruction potentially worse. Now, if the patient has a stoma and they're trying to breathe for them, the patient that's got that hole cut in the middle of their throat, and that's where they breathe out of. They don't actually breathe out of their mouth. So you put that bag valve mask over their face, it's just going to blow air out that hole like it would a blowhole on a whale. So you don't really want to mess with that. It just kind of defeats the purpose. So you need to breathe through that stoma. Now, people chronically who have stomas can develop a lot of mucus and stuff in there because they don't have the same airway passage of air coming in that nose, getting nice and humidified. They develop a lot of mucus. So you may have to be suctioning out that mucus routinely to be able to provide that ventilation so you're not shoving the mucus down in there. So just leave the head and the neck neutral position, and you'll take the pediatric size mask off of that pediatric bivalve mask, and all those masks are interchangeable between those bags. So put the real small mask on the real big bag, and you just use that as a seal, because that stoma is just about the size of a 50-cent piece. So you'll need that smaller mask to create that better seal. But they do make a stoma seal, but the chances of actually carrying one of those on your ambulance is very, very rare. So you just need to kind of adapt and overcome. One of the primary things you're going to do to be managing somebody's airway is giving them oxygen. Sometimes you have that simple hypoxic patient and you catch them early enough in their exacerbation. And when you hear me say the word exacerbation, that just means another moment of it happening, to where if somebody's got COPD and they live with it all the time, the exacerbation just means that their chronic condition, which is normally stable, has gotten worse. So the importance of supplemental oxygen. We need to remember oxygen is a drug. You just can't go out and have oxygen and start giving it to everybody. It is a prescribed medication. It can be harmful. There's a lot of research out now to where people are getting over oxygenated, where just not that many years ago, just like give everybody oxygen, they can take enough of it, it won't hurt anybody. Now there are some instances where people have gotten too much oxygen and it's causing some harm to the cells from way too much oxygen and a crazy thing called free radicals. So once again, just refer to all your protocols, everything that's going on, and whatever the underlying cause is of if they're going to need oxygen, and we'll talk about the oxygen delivery routes. So your oxygen you carry anymore is going to be in these aluminum bottles. Some places are still carrying steel bottles to where they're completely a solid green, but anymore a lot of places are just carrying the aluminum bottles because they're a lot lighter and they're easier to lug around in a bag. So these are portable containers that you're going to carry just in a duffel bag or something on your ambulance. And the way to tell the difference between the portable ones is these just have little valves where they got one hole and 2 connecting prongs on here, and these square stems at the top. The non-portable ones have a round valve on them, has a twist top on them, and then this flow regulator mounts onto those. And this is the example of the non-portable one. These things are extremely heavy. As you see here, this piece of apparatus has a loading system to load this very large oxygen cylinder up in there, to where this could hold. This is going to supply all the oxygen connections in the ambulance. Now the oxygen cylinders, they come in multiple sizes and shapes. The D cylinder, the smallest one, it only holds about 350 liters of oxygen. E cylinder, one of the most common ones, 625. M cylinder at 3000. And the G and H cylinders, these are going to be the cylinders used as your primary cylinders, that big large ones that sometimes have to use a piece of equipment to load up into the ambulance. So these are the one that all your oxygen connections in the ambulance are fed off of. The oxygen cylinders, they are under high amounts of pressure, so they do have a regulator on them to control that flow. So because you don't want several thousand pounds of air to be pushing against your patient's mouth, that does a lot of damage. So there's regulators on there that limit that flow, keeps the volume in there, so you're not delivering high pressure oxygen to that patient. Make sure whenever you do connect those flow regulators that they are sealed, but you'll know whenever you try to open that up with that high pressure out of the cylinder, you'll hear the hiss and the leak that if anything's not coming out right, or if there's not a good seal, you got a blown gasket or something like that. Whenever you open up an oxygen cylinder, whether it's your main valve or your portable one, you just want to open them all the way and then go back about half a turn. So that way, if you open it all the way and somebody thinks that it's not open and they try to open it, they're going to think it's really stuck and they could potentially break the stem. So if you open it all the way, back just half a turn. So if they don't realize it's on and they go to open it, they turn it half a turn and they realize, oh, it's already open. The oxygen cylinders, with all OSHA regulations and stuff, they have to be stored in a safe, cool, ventilated area. Since they are under high pressure, you need to be very cautious with them, because if you drop them, they can end up going off like a rocket. If they drop and the top of it breaks off and all that air releases at once, they're just a missile waiting to go. So big cylinders generally need to be stored standing up, locked and chained in, just like in ambulances that are highly secured in there so they don't beat and bang around as the ambulance travels down the road. And the other reserve ones that are in the stations, they're generally locked up in cabinets or chained up against the wall and locked up. Otherwise, if it's portable ones, you just want to leave those laying down. And of course, never smoke around the oxygen cylinders and never around any open flames. Oxygen's not flammable, but it does make a flame very big. And just other little safety things, you don't want to use any kind of adhesive tapes on the valves or anything that could interfere with creating that seal around the valve, or any kind of issue that can damage the cylinder. So here's a picture of a pressure regulator. Basically, it lowers that internal pressure, generally around 3,000 psi of these big cylinders, to a good safe working pressure of 30 to 70 psi, because that's a lot more easier to control than that much higher one. Different types of flow meters. The flow meter you see on the left is a common type one you're going to see that's on the wall mount in the ambulance. And as you see here, you got this little floating ball. So you twist this knob, and as oxygen flow comes in, this ball will go up and down. So that's where you can see how many liters per minute of oxygen you're going to be administering. Now in this picture, this one only goes up to 5, but all the other ones generally go all the way up to 15 liters a minute. This one on the right, this is what goes on the portable oxygen cylinders that you'll take into a residence. So it's got your pressure, it's got your volume gauge on here, letting you know how much oxygen you have left. And over here is the twist knob that you'll turn, and you can see the number over here where you'll select what flow you're going to set it at. As this one you see here, set at 2 liters a minute. So the oxygen you connect to it will go into this little stem right here. Another picture of a flow meter, but this is the high pressure side. So we talked about that CPAP and the BiPAP. Those connect to here because those systems are driven under high pressure flows. So even though that's connected here, you can still connect your other oxygen systems over here, and there's a twist knob on the side here and a little viewer here of how much air you're going to deliver here. So you see on this pressure gauge here a little bit more clear to where you've got low, This one's, of course, out of air because it's not connected to anything, but you would see how much remaining pressure you have in that cylinder. Also, a form that can be connected to oxygen delivery is humidifiers. Oxygen, if you have a person on oxygen for a substantial amount of time, it can really dry out their passages, especially if they're just on nasal prongs and a high concentration of oxygen's flowing through their nose. It'll dry out those nasal passages, where the nasal passage's job is to humidify. But if it's high, that oxygen flowing through in higher concentrations, it will dry it out. So you've got this sterile water set down here, and your oxygen connects to it. So the air blows in here, it humidifies that air, and it goes out into the oxygen delivery. Some hazards of oxygen delivery. These are more of the rare situations of that oxygen toxicity. It can happen, but what we're looking for is that oxygen saturation up to 99%. All the research shows that if you have oxygen saturations of 100%, that you don't know if it's just right at 100%, exactly what the body needs, or if there's way too much oxygen in there. And a healthy person, that's not going to hurt them, but somebody potentially having a heart attack or some kind of tissue that's already damaged and irritable, those crazy high levels of oxygen being administered to them can end up causing them some damage. Infant eye damage, if you do have to administer oxygen to any wee little kids, especially the newborns, that oxygen can actually dry out the membranes of the eye, just like it will dry out the nasal passages. It'll dry up all the fluid and stuff around the eyes, causing eye damage to those kids. So if you do have to give them any kind of oxygen, just make sure it's not blowing straight into their eyes. Also, respiratory depression, respiratory arrest. There are rare cases out there to where, say, chronic lung people, say COPDers, they maintain what's called a hypoxic drive, to where they kind of maintain that low levels of oxygen all the time, that if they start getting high levels of it, their body's kind of used to running one way and it doesn't do good with this way. But that's if one of those patients is on high concentrations of oxygen for a very long time. But if you do have one of them, you give them on high oxygen concentrations and you're someplace rural and you have a long transport, just keep an eye on it that they're not starting to have a decreased mental status or their respiratory rates slowing down, that making sure they're still got good rise and fall of the chest, adequate respiratory rates, always continually checking on that chest rise and fall and their airway. The ways that we deliver oxygen is generally through a non-rebreather mask, which as you see here, and the way to identify a non-rebreather mask is these little valves on the side. So basically what that is when they breathe out, it goes outside that mask and not down into this bag, so they're not breathing in the same thing as they breathe out. Now, I'm sure you've seen in movies and stuff the technique of telling somebody to breathe into a brown paper bag. That's just a placebo effect. That's just so they can see that bag inflate, and it just lets them focus on that, because that's for anxiety people. That's not a medical procedure at all. That's making them rebreathe everything they've just exhaled. So you get everything out of your body for a reason. You don't want to inhale that back in. The non-rebreather is used to deliver higher concentrations of oxygen. So you're looking at delivering concentrations of 80 to 100% oxygen. And just with that bag valve mask has that reservoir bag on it, that non-rebreather mask does too. So they're going to be taking in deep breaths of high amounts of oxygen. Now when you connect your non-rebreather mask to an oxygen source, you set it anywhere from 12 to 15 liters a minute. So that's going to give you that range of 80 to 100% oxygen. A nasal cannula, this is the best option for somebody who needs oxygen, but they just can't stand to wear that non-rebreather mask. Some people don't like that mask, makes them feel smothered, whatever. So this is just a delivery method that will administer oxygen through their nose. Or if people have just a slight difficulty in breathing, nothing crazy, they don't need high levels of oxygen, you can use that nasal cannula to deliver oxygen the same way. So here's your nasal cannula. You've got the two prongs that go into the nose, and that's where the oxygen comes in each of those valves, into one nostril and the other nostril. Then this would connect into your oxygen supply. So these prongs will go in your nose, then this lash will go around your ears, and then you'll see the little cinching mechanism right here will cinch in underneath your chin. As the non-rebreather delivers 80 to 100% oxygen, the nasal cannula is only 24 to 44%. So that's just going to give him about a little less than half of the oxygen that non-rebreather does, because this kind of has a smaller volume going in, and it also is just kind of mixing with the atmospheric air, since there's not a seal, there's not that rebreather bag, everything like that. So as it goes in the nasal prongs, you're going to want to set that at 2 to 6 liters a minute, just depending on how much you think that they really need. So you never want to go any more than 6 liters a minute on that nasal prong. That's just going to be way too much airflow and too much pressure going into the patient's nose. A tracheostomy mask is used to go over that trach. So you would set that at 8 to 10 liters a minute for your oxygen supply. As the picture here shows, it would go and seal around the hole that's in the neck right here, and it's got that elastic band that goes around, and your oxygen supply would click in there, and you set that once again. Some special considerations when dealing with a patient's airway. As we've talked about before, those facial injuries, trauma, can end up having that swelling, bleeding, other stuff in there. So once again, being aggressive with that suctioning, keeping that airway clear. So every once in a while, dip that yonker tip in there, see if you can even suction anything out. Just because you don't hear anything or see anything doesn't mean that there's starting to be some fluid buildup in there. Those foreign body airway obstructions, need to be always cautious of those, keeping that airway clear. If there's any kind of foreign body airway stuff in there, you need to get it out one way or another. Where you got to start doing the Heimlich maneuver, using suctioning, calling for a paramedic and their advanced airway techniques to removing objects from the airway. Those dental appliances, as I said in the last time, you need to leave that stuff in there. That's really going to help you make that seal with your bag valve mask or your pocket mask or your CPAP, BiPAP, whatever it may be. You know, you see those old people don't have any teeth, their cheeks are kind of sucked into their face and they got an odd shaped face, and that's not going to allow you to make a very good seal, with that seal being the hardest part of the airway. So leave those dentures in if you can, unless you think that they're too loose and it could potentially become an obstruction in that airway. With the kids, that hypoxia is a quick cascade. They can decline very fast. In fact, the airway is the most important part of that kid. The number one reason why kids die is because of airway issues. So that hypoxia can occur very, very, very fast. And that's all just due to the anatomy of the little kids. They consume oxygen twice as fast. They don't have much of a tidal volume. They're breathing really fast. So just that little bit of change or something skewing it is going to make a kid become hypoxic and crash very fast. So when you ventilate those kids, be very cautious, because they got those wee little lungs. They're still starting to develop, so you can actually pop a lung if you aggressively ventilate and blow too much. And remember that the kids are belly breathers. You do see their bellies move to get that breath in, but when you ventilate, you're still looking for rise and fall of that chest. You're not looking for the belly to inflate. If the belly of anybody's starting to inflate when you're ventilating them, you're doing it wrong. Always just be sure that you're using the appropriate size stuff with them. Now we'll talk about assisting with some advanced airway maneuvers. So there's more stuff being taught of teaching EMT how to help with such techniques as a paramedic intubating. There's two types of advanced airways. There is what's called a blind airway device, which is one that you don't have to see any of the internal airway anatomy to insert, which is what an EMT can do. And then there's also the direct visualization, which is what paramedics do when they put their blades in, lift up the tongue, they see the vocal cords, they insert the tube right into the trachea. You see here is a picture of a paramedic intubating. They got the blade, they got the light, they're lifting up on the airway. So there's a couple methods the EMT can do to help in this. One, an EMT important role of them is to help the paramedic be doing the intubations, as well as you see here in this picture. You got the EMT's hand right here performing what's called a burp maneuver. So you hear backwards, upward, right pressure. So you'll put your finger and your thumb right here over the cricoid cartilage. You're going to push backwards, upwards, right, and that's to the patient's anamus. You'll basically kind of push down and up, aiming for that patient's right ear. What that'll do, that'll allow some more of the anatomy to come into view for the paramedic while they're intubating. Also, big roles of the EMT here is the ventilation aspect. When the medic is doing other stuff, the EMT is going to be providing the oxygen, doing the ventilations, listening to the lung sounds, and helping secure that tube. So there's different techniques into doing all that, and we'll cover all that in lab of securing that tube, taping it to the face, using a commercially made securing device, whatever it may be. You need to be sure to secure that tube though, because very little movement can make that tube become dislodged. So all that hard work was just done to intubate that patient. One big bump, one slight miss or jerking of that tube can dislodge it completely, and then you've lost the patient's airway. So as you're bagging that patient, which you'll just take the mask off, that bag valve mask, and you'll just connect it straight to that ET tube and breathe right through that tube, right directly into their lungs. So if you feel any weird resistance on the bag, say if you were initially ventilating a patient who wasn't breathing and now you feel some resistance or you feel some different stuff, could mean that patient's breathing again, could mean you've got obstruction in the tube. Different resistances mean different things, so it's something you need to be checking on, make note of. If it does occur, you need to notify somebody, report that has happened. If the patient's in cardiac arrest and are going to be defibrillated, the patient's going to be shocked, you need to take that bag valve and remove it from the ET tube. And the reason for that is there's high concentrations of oxygen flowing through that. If that patient gets shocked and a spark is delivered around that high concentrations of oxygen, you there now have a fireball in your hands, and you've got a flamethrower catching your patient on fire, and ain't nobody got time for that. And also, be keeping an eye on that patient's mental status. So you'll see here, this is a picture of a patient who has been intubated. You got the ET tube, it's secured here, they're on a hard backboard secured, and you got your bag and your valve, no mask, just connects right to that ET tube, and you ventilate the same way, except you don't have to worry about making a seal because that tube's straight down into the lungs. Now when you have to assist with the trauma patient who's about to be intubated, you're going to have a big role of maintaining that cervical spine, doing a stabilization, and holding the head while the paramedic performs the intubation. Now the blind-insertion airway devices, this is what the EMT uses as an advanced airway. Basic one, the most common one anymore is the King airway. That's probably what the majority of the country's doing now, and most predominantly in this area, this is what everybody's using, is the King airways. The combi tube's still out there, just not nearly as common as it used to be. And with these, you don't always necessarily have to worry about positioning the head. They go in, you just basically size them and slam them right down in. Not a whole lot of rocket science to them. They're pretty simple devices. It's just a tube with some inflatable cuffs. You got two cuffs here and your connection here. So a syringe will connect to this and inflate these tubes once it's inserted in. So you see the anatomy of the picture over here as it's put in, and remind you, these cuffs aren't inflated, they're deflated whenever it goes in. So it's lubed up, it's pushed in to the appropriate marks, and you connect your syringe here, inflate this tube, and it inflates both of these bulbs. As those bulbs inflate, it lifts that tongue up, and this next bulb down here seals off the esophagus, so it protects that airway. So no stomach contents can come up past this and be getting into the airway. However, some stuff still can get into here a little bit, so you gotta still be cautious. And this would be one of those instances where you could use a flexible or soft suction catheter, stick it down in the tube, suction out any material or anything that gets into that tube. King airways do come in multiple sizes. They're color coded for size. As you'll see here, the yellow is a size 3. This is essentially for patients 4 feet and taller. The red, size 4, patients 5 feet and taller. And the purple, size 5, for patients over 6 feet tall. Now you also note here that the cuff volume is a little bit different the bigger that they get. Now on these King tubes, in this area right here, we'll tell you how much air you need to inflate on each one of these cuffs. Also right there is the size number of each one of them. So if you just read right here, tell you basically everything you need to know about those King tubes, how much you need to put in, everything else. Also in this area here are a set of numbers. So when you insert this and you inflate it, you ventilate them, everything's secured, you'll note that number that's on there and where that aligns with the mouth or the teeth, then you document that. So then you know that once it's secured, that if you go over a big bump and you document it as soon as it went in that it was at 20, you go over the big bump, you see it's still at 20, everything should still be okay. So finally, in closing, we'll watch a video on inserting the King airway tube, and if you have any questions, feel free to email me. Thanks.
Quick review on the use of the King airway. This happens to be the LTSD, which is the version with the gastric access port, but the insertion and inflation, from a ventilatory standpoint, it's identical to the LTD. Kind of 3 things to remember. The first challenge may be in getting the tube around the corner, the tip around the corner in the posterior pharynx. And because the tip is relatively straight, if you just try and go in, oftentimes the tongue falls back and wants to make the tip not want to go around the corner and go into the esophagus. So there's a couple of things, managing the tongue with your thumb or a tongue depressor or a standard laryngoscope blade, or actually even coming in from the side and then rotating the tip into position. But at any rate, the key is to get that tip around the corner and advance towards the esophagus. The second challenge is how do you make sure that the ventilatory openings are aligned appropriately with the airway inlet. We suggest, and this is the first step of this, to insert the product all the way because of the distensibility of the esophagus. This is typically possible, so you put the connector all the way to the teeth. Now that may be too deep in some individuals, but we suggest you start out in this position. Next, and we'll touch on the third element, and that's cuff inflation. To inflate both cuffs with a single line, it's going to take 60 to 70 cc's, a little more in big patients, a little less in small patients. Both the distal cuff and the proximal cuff are inflated with one balloon. And I point this out because if you are only using 20 or 30 cc's, which might be appropriate for an LMA, it's not going to be good enough for the King airway. Next, as you try and see if you've got an airway or not, in this case you can see I do. But if I didn't, because the tube was too deep, I would merely back this up until I actually got a good airway, and that way I know that those ventilatory openings are appropriately aligned with the ventilatory inlet. At this point, you can make sure that the cuff inflation volume is matched to this particular patient by either using a pressure gauge or by inflating or deflating with the cuff until you get a just leak condition at the ventilatory pressure you're employing, and then just give a little bit more so that you make sure you have a seal. Now, one of the things I like to demonstrate with this device is you can actually hook up to the pressure port of this pediatric resuscitator bag, and with the cuff pressure gauge, illustrate that you can actually get extremely high ventilatory pressures. This is a fundamental feature associated with all the King Airways, that you get an extremely good ventilatory seal. And this is a reflection of the seal in the esophagus, so it prevents air from getting into the stomach, and also prevents air from coming out the mouth past the proximal cuff. So those two cuffs are above and below the opening of the airway and sealing it off. And for further safety, you can actually use the gastric access port to put up to an 18-French gastric tube down into the stomach and evacuate the stomach contents. The gastric access port is on the back side, and so this illustrates how you're capturing on the fact that you're already in the esophagus with the tip here. Now the airway openings are here trapped between the cuffs. So this seals in the oropharynx above the airway opening. This seals in the upper esophagus, and so you prevent air from going into the stomach and you prevent air from coming out the mouth. And as further safety, you can decompress the stomach so that none of the stomach contents are likely to come up and cause a problem.